It's time for the 3-question warm-up for Endocrine 1. Let's get going. What is the treatment for neuroleptic malignant syndrome? So dantrolene is the main thing that we use here, and if dantrolene is not effective, or in addition to dantrolene, you can actually use something like a dopamine agonist like bromocriptine. Next, what is the most common complication of recurrent otitis media? That's going to be hearing loss. So hearing loss is the most common complication. Next, what is the treatment for delirium tremens? So sometimes referred to as the DTs. So DTs are due to alcohol withdrawal. So you give a long-acting benzodiazepine. So chlordiazepoxide is one that we use for that. All right, so that's going to bring us to the end of our warm-up. Let's get to that video.
Hello, I am Mary Beth Cox, a clinical endocrinologist, and I'm going to be giving your endocrinology lectures. The first few videos in the endocrinology section are going to focus on diabetes, and this is one of the most prevalent diseases in the U.S., so naturally diabetes is extremely high yield for your test. We'll cover type 1 diabetes in this video, and then type 2 diabetes in the next one, including the various oral therapies for type 2 diabetes. In that other lecture, we'll also walk through the ins and outs of insulin therapy, DKA, and the long-term complications of diabetes. So the very first thing on page 110 of Step Up is normal glucose metabolism, which is pretty basic stuff and the key physiology that's impaired in both types of diabetes. However, even though I find it all extremely interesting, these details are not terribly high yield for this exam. Basically, insulin is produced by the beta cells of the pancreas, primarily in response to eating carbs, and then insulin moves the glucose into the cells so the cells can use it, either immediately for energy or to store it as glycogen or fat for later. And you can read through that section on your own as a refresher if you need to, but there's nothing bolded here. So let's move on to type 1 diabetes. The older names for this include juvenile diabetes, although most commonly in children and teenagers it isn't always, or insulin-dependent diabetes, which is very confusing because people with type 2 can also use insulin. So we don't really use those names anymore, just type 1 diabetes. Type 1 diabetes is caused by a loss of the ability to produce insulin, most often caused by autoimmune destruction of the beta cells. You definitely need to know that. Type 1 diabetes is an autoimmune disorder where there's destruction of the beta cells in the islets. The primary deficiency is the absence of insulin. This is a different process than type 2 diabetes. So to diagnose type 1 diabetes, use mostly clinical judgment, along with abnormal glucoses on the labs, of course, and we'll talk more about those values in a minute. But even when the diagnosis of diabetes is clear, determining the type of diabetes can be confusing. But it's a really important distinction to make. For example, say you're seeing an obese 18-year-old patient who comes in with new onset diabetes. There might not be family history, and you're not sure if this patient has type 1 or type 2, so to help you decide if he needs insulin right away for treatment, or if you can start with an oral medication, you can do some lab testing. There are a few labs you can use together with your clinical acumen. So first, you can check a C-peptide level, and you might remember that this is a piece of the endogenous proinsulin molecule that gets chopped off during processing. In type 1 diabetes, you would expect it to be very low, often undetectable. There also are some specific antibodies you can check. Look at your study guide. What anti-islet antibodies can be seen in patients with type 1 diabetes? So the antibodies are anti-insulin antibodies, or IAA, anti-islet cell cytoplasm antibodies, anti-glutamic acid decarboxylase antibodies, or GAD, and anti-tyrosine phosphatase antibodies. You don't need to get bogged down in memorizing all those individual antibodies. I mostly use the GAD, as in, EGAD, this patient needs insulin now. Good to know this is out there because clinically it can help you. So back in Step Up, Part B, number 2, says type 1 diabetes has an association with the HLA-DR3, DR4, and DQ genotypes, so can be hereditary. And then the quick hit also says rubella, Coxsackie virus, and mumps have been associated with onset of beta cell destruction. Frankly, many viral infections can tip it off, although these few have been more documented than others. So let's talk for a minute about clinical features of onset. First, type 1 diabetes often is diagnosed in children, and almost always in people under 20 years old. Remember, it used to be called juvenile diabetes. There's a bimodal age distribution for the age of diagnosis, with one peak at 4 to 6 years of age, and then a second peak around 10 to 14 years with puberty. Then the distribution tails off and people can get it later in life as well. Although in your exam, you're most likely to see the younger patients. On your test, they might give you a child presenting with nausea and vomiting, but no diarrhea. It's tempting to think, well, this is gastroenteritis, but take note of the absence of diarrhea, which means it's not gastroenteritis. So isolated nausea and vomiting in a young patient could be diabetic ketoacidosis as the initial presenting symptom of diabetes. So if a child comes in with nausea and vomiting but no diarrhea, think about DKA in your differential. More commonly, patients will present with abrupt onset symptoms but more subtle than full-blown DKA. Remember, the physiologic insult is inadequate insulin production from beta cell destruction. So patients can't move glucose out of the blood into the cells, so they get hyperglycemia or high blood sugar. I'm guessing you've got that one. I like to call the others the polys. So the kidneys try to move the excess sugar out by dumping it into the urine. This causes an osmotic load that draws a lot of water into the urine. So they have polyuria, excessive urination. That's a classic symptom of diabetes. Because of the polyuria, they're also losing a lot of water, so they get polydipsia, or excessive thirst. So they're drinking a lot of water, or soda, or juice, or Monsters, or whatever, and sometimes this is really making things worse and they don't even know it. They're also not really getting the calories they need from their food because they're losing it all in the urine, so they get polyphagia. They're eating a lot. And they may have some weight loss, again because of the calorie loss in the urine. And type 1 diabetes tends to have a more rapid onset than type 2. Many times people can tell you the date their symptoms started, and as I said before, sometimes this corresponds with a viral illness or something. The lab abnormalities you see are pretty straightforward. Obviously hyperglycemia, then there's glycosuria, that means glucose in the urine. You can see serum and urine ketones because the body is starving for energy, so it's breaking down triglycerides into fatty acids and converting them into ketones. These are not diagnostic for diabetes clinically. There can be ketones in the serum and urine in someone who's fasting or someone who's on a very low carb diet, but typically on the exam you'll see them with diabetic ketoacidosis. Most kids aren't on a very low-carb diet anyway. So if you see ketonuria or ketonemia, particularly in context of the GI symptoms or the polys, then that's probably ketoacidosis. Next, you can get increased hemoglobin A1C. The A1C is a piece of the hemoglobin molecule, and as it floats around in the blood, glucose sticks to it in a non-enzymatic, irreversible reaction. So the more glucose in the blood, the more sticks to the hemoglobin molecule, or the hemoglobin becomes glycated. This amount of glycation can be measured as a percentage, and the different A1C percentages have been correlated with average glucose levels in many, many people. So we have standardized normals. And patients without diabetes will have an A1C in the 4 or 5s, but if the glucose is always high, the A1C will be higher too, even up into the double digits. So we can use the A1C for diagnosis of diabetes and also to monitor how well the diabetes is controlled. If you're a sports fan, you can think of the A1C as a batting average for a season. It's a good indicator of how someone is doing overall, but it doesn't give much information on day-to-day variability, sort of like a player's single-day record versus the season. At the top of page 111, there's a table that lists the diagnostic criteria for diabetes. And when you're trying to make a diagnosis of diabetes, you can use a glucose-based test, which has to be correlated with the last food intake so you can know what cutoffs to use. Or you can use the A1C we just reviewed. For asymptomatic patients, it's usually good to get 2 different results to be sure the diagnosis is for real. The first type of glucose test is a random glucose, or timing with food is not known. If the random blood sugar is over 200 and the patient has the polys and weight loss, that is, the symptoms of diabetes, that's diagnostic enough. Just having a blood sugar of 200 by itself doesn't diagnose diabetes unless they also have the symptoms, although it's pretty suspicious. More commonly, you'll see a fasting plasma glucose, which is a glucose checked after at least an 8-hour fast. This diabetes cutoff is 126 or greater. Like all the glucose-based tests, you'll want to see it more than once to confirm. So if you see a patient with a fasting glucose of 140, for example, which does meet the diagnostic criteria of greater than what? Yes, 126. The next course of action would be to order another test to confirm. An older kind of diagnostic test is an oral glucose tolerance test, which measures the glucose 2 hours after a person drinks 75 grams of glucose. This test is pretty inconvenient, so it's limited usefulness despite being the most sensitive test. Anyway, you give the patient this gross, syrupy, sugary glucose solution to drink, and then you check the blood sugar 2 hours later. And the blood sugar cutoff here is 200 or greater, same as for a random glucose. Many people who use this test will have patients come in fasting, do a lab, then have people drink the glucose and wait and do another lab. This way you get both the fasting glucose and the 2-hour glucose tolerance test in the same day. And then a fourth test is the only non-glucose-based test, which is an A1C greater than or equal to 6.5%. This has only become accepted as an official diagnostic criterion in 2010, so it's still relatively new, but you should definitely know it. It's so much more convenient than the glucose-based testing that it's kind of taken over on diabetes screening and diagnosis, although it's a little less sensitive than the OGTT, that's the glucose tolerance test. And again, a patient only has to meet 1 or 2 of these criteria, not all 4 of them. And we're not going to go into detail, but be aware that there is an in-between category for patients with glucose higher than normal, but not high enough to diagnose diabetes according to these criteria. This is prediabetes, which can be divided into types: impaired fasting glucose or impaired glucose tolerance, depending on the timing of the abnormality and the test use. The cutoffs for these are a bit lower than those listed for diabetes: A1C 5.8 to 6.4%, a fasting glucose 100 to 125, and 2-hour glucose tolerance glucose of 140 to 199. That's a detail you may not need for the test, but good to hear it anyway. At the bottom of page 111, we're going to skip treatment for right now, except to say that type 1 diabetes requires treatment with insulin. And when we get to type 2 diabetes, we'll talk about all sorts of oral medications that we can choose from. But remember, with type 1 diabetes, those beta cells have been destroyed. These patients can't make any insulin. So if you don't give them insulin, they're going to get very sick and die. So we'll talk about the different types of insulin and the different insulin regimens in another video. But for now, just remember that type 1 diabetes has to be treated with insulin. So now let's talk about an important risk of treating type 1 diabetes. This is not the long-term risk or complications like retinopathy, neuropathy, nephropathy, and atherosclerosis. These are so important that we have set aside an entire video to talk about complications of diabetes. In fact, atherosclerosis causing heart disease is the #1 cause of death in people with diabetes. But what we're going to talk about now can happen acutely, and this is hypoglycemia, or low blood sugar, which in type 1 diabetes is exclusively from taking too much insulin for the situation. However, there are other potential causes of hypoglycemia, and even though they aren't all related to diabetes, this seems like as good a place as any to go into some discussion on the topic. Let's skip over to the very bottom of page 114 and spend the rest of this video talking about that. On the scale of test importance, hypoglycemia is lower than diabetes overall, but you might get a test question on this, and it's actually sort of straightforward, so worth looking at. On the next page, you'll see a list of several clinical manifestations, including faintness, weakness, diaphoresis, and palpitations, which are related to the body's hormonal response to hypoglycemia. When the sugar goes down, the body releases 5 counter-regulatory hormones, including epinephrine, to counteract the problem by mobilizing glycogen, among other things. And with this, there will be the increase in sympathetic tone and symptoms you would expect from too much epinephrine, like fight-or-flight style symptoms. Other symptoms can include headache, confusion, mental status changes, seizure, and loss of consciousness, which occur because of inadequate supply of glucose to the brain. So one quick consideration on symptoms of low sugar related to epinephrine. What do you think might happen if a patient is taking a beta-blocking medication? Yes, beta blockers can mask the symptoms of hypoglycemia. So let's talk about some of the causes of hypoglycemia in Table 5.5. Clinically, you may never see any hypoglycemia caused by something other than medications for diabetes, but on the exam it might be there. So let's do iatrogenic hypoglycemia first, since this is the most common and oftentimes the most obvious. It's caused by excess insulin administration or as an adverse effect of sulfonylurea use. Not all diabetic medications will do this, but these will. To diagnose iatrogenic hypoglycemia, usually all you need is a history. It's not a big mystery. The patient will tell you, I accidentally injected 20 units of insulin instead of 10, or, oh, I took my insulin and then the phone rang and it was my daughter calling from Cleveland and I just forgot to eat. Or maybe it's overdosed on the prescribing end, like you've been a little too aggressive in titrating the patient's insulin regimen, and now your patient keeps getting sugars into the 40s. So you can usually figure it out without too much trouble, and then you just adjust the medication regimen. maybe it's time to get off that sulfonylurea and switch to something else. Or maybe you need to change the timing of the insulin. Very occasionally you will see someone who's malingering or who accidentally has the wrong pill in the wrong bottle or something. This can be sorted out with lab testing. You might check an insulin level, and if the insulin level is high while the glucose is low, you know that's a problem. But it's not very specific. You have to have other evidence that the insulin is exogenous, like low C-peptide or proinsulin with the same clinical picture. So remember, when insulin is made in the beta cells, it's synthesized as a long polypeptide molecule called proinsulin. It kind of coils up and gets cross-linked, and then some enzymes cleave the polypeptide, so you're left with a molecule of insulin and a molecule of the C-peptide, which gets secreted into the blood along with insulin. If the patient's giving too much exogenous insulin, those bottles of insulin that come from the pharmacy contain just insulin, not C-peptide. So in this case, the insulin level would be high, but the C-peptide and proinsulin levels are low. This would be different in a patient that has an insulinoma, as we're going to discuss in a minute, who's going to have high levels of everything, insulin, C-peptide, and proinsulin, because it's all endogenous. This can get a little confusing with sulfonylurea overdose, which can cause an increased production of endogenous insulin. And so you have to be sure you get a complete panel of labs before you start fishing for these very rare tumors, the insulinomas that is. So anyway, the insulin level is bolded, but not unique for insulin overdose. The same thing is listed in the next row under insulinoma, as I just said. You can also check blood levels of sulfonylureas in a special send-out test. Next, I want to mention reactive hypoglycemia, which until recently had been pretty unusual. However, it's becoming a little more common now since many people are having gastric bypass surgery. And it particularly can be a problem for people who had insulin resistance prior to having gastric bypass surgery. But let me interject that a lot of people having gastric bypass surgery have insulin resistance and diabetes prior to surgery, and most of them don't get this. So the pathology here is an exaggerated insulin response to the carb intake. So to put it kind of casually, the pancreas is used to trying to overcome a lot of insulin resistance by overproducing, and it doesn't realize the insulin resistance has improved since surgery, so it overshoots, and then people get low sugar. Some people can get a similar process, although usually to a lesser degree, when they're developing type 2 diabetes. And it can even happen in people who have normal glucose numbers when they eat a lot of junk or high-carb food. So with this, the sugar usually doesn't get dangerously low, just enough to cause uncomfortable symptoms. So you might see patients who come to you saying, I get hypoglycemic, but they probably just need to eat more protein and probably much less junk. So reactive hypoglycemia after gastric bypass is a real problem though, and often these patients do need medication to treat. So next up is insulinoma, which is an insulin-secreting tumor usually found in the pancreas. This is pretty uncommon, and we'll also cover it in the GI10 video on the pancreas. So again, to make the diagnosis, you're going to have increased insulin in the presence of hypoglycemia, along with other tests confirming that the insulin is endogenous, just like the elevated C-peptide levels. So anyway, once you have biochemical confirmation of too much endogenous insulin production, the job is to locate the usually tiny insulinoma, starting with either a CT or an MRI. And this sometimes gets kind of complicated, but assuming you find it, the treatment would be surgical resection. If you can't resect it for whatever reason or can't find it, there are a couple of medications that you can use. One is diazoxide, which is a medicine that shuts down insulin secretion, and the other is octreotide, which is used to shut down a lot of GI hormone production and can be used to try to improve symptoms from insulinoma, VIPoma, carcinoid, and others. Neither of these is really super effective. Surgery really is best. The next cause of hypoglycemia is just hypoglycemia seen during a fasting state. But here there has to be some other underlying problem like malnutrition or liver disease or hormone deficiency. Because most people don't get hypoglycemic just because we miss a meal, right? I mean, surely you've never missed a meal during your third-year rotations. I mean, when the glucose drops and you start taking glucose out of storage to keep the serum glucose levels normal. But some patients have liver disease or something else that blocks this normal mechanism, so they can get hypoglycemic if they miss meals. And this is best treated with proper nutrition and, if appropriate, an enzyme replacement. Alcohol-induced hypoglycemia is seen when there's a depletion of glycogen and inhibition of gluconeogenesis because of high concentrations of alcohol. If there's a lot of alcohol in the system, all the NADPH is being used up to metabolize that alcohol. And if the NADPH is all occupied with the alcohol, The liver can't facilitate gluconeogenesis, so there isn't enough glucose synthesis to counteract potential fasting hypoglycemia. Alcoholics will also sometimes just quit eating altogether and will only drink alcohol, which could also lead to hypoglycemia, as in fasting. So how do you counteract this? Well, proper nutrition, of course, and stopping the alcohol abuse. Now, as a side note, what if an alcoholic patient comes into the ER with obvious hypoglycemia? What do you need to give that patient other than glucose? Remember, it's important to give thiamine before you give glucose to potential alcoholics to prevent Wernicke encephalopathy. Then the last cause of hypoglycemia to discuss is pituitary or adrenal insufficiency. We'll talk about pituitary disease and adrenal disease a little later in the endocrinology section, but basically cortisol is involved in regulating gluconeogenesis. So if the adrenals aren't making cortisol or if the pituitary isn't making ACTH, there will be decreased cortisol and increased risk of hypoglycemia. So that's it for hypoglycemia. Let's go ahead and do the end of session quiz. First question, what lab test is used in diabetic patients to assess the adequacy of glycemic control over the last 3 months? Hemoglobin A1C. What is the leading cause of death in people with diabetes? Cardiovascular disease. Why must beta blockers be used with caution in diabetic patients? Beta blockers will mask the sympathetic symptoms of hypoglycemia like tachycardia. And what can cause hypoglycemia in a non-diabetic patient? Insulinoma, using insulin or sulfonylurea to induce low blood sugar levels like factitious disorder, Munchausen, or malingering. Alcohol, fasting plus an other underlying disease like liver failure. Adrenal or pituitary insufficiency. You would really need something in the question stem to point you toward one of these things. And what causes hypoglycemia in people with diabetes? Almost always medications, too much insulin or other diabetes drugs, which we'll cover later. So that's it for now. I'll see you in the next video.